Hello everyone and welcome to today's webinar. On behalf of EchoSyn's North America, I'd like to thank you for joining us for Interpreting Liver Stiffness and CAP Scores in Clinical Practice. My name is Sarah Alspaugh with the GoToWebinar team, and I'll be supporting you for today's webinar. Before we get started, I just need to go over a few items so you know how to participate in today's event. You have joined this presentation listening using your computer speaker system by default. If you would prefer to join over the telephone, just select telephone in the audio pane and the dial-in information will be displayed for you. Everyone has entered in listen-only mode. This simply means that you are muted so we don't pick up noise from your end. However, you will be able to hear and see today's presentation. We do offer the opportunity to submit your text questions for the presenters. So if you can find the questions pane on your GoToWebinar control panel, that's where you can type in your questions at any time. And we'll collect these and address them during the Q&A session at the end of today's presentation. If you have any technical questions, please type those into that same question and I will address those as they come in. Today's webinar is being recorded and you will receive a follow-up email with a link to view the recording. I'd now like to turn the webinar over to Jerry Mayberry of EchoSyn's North America. Welcome, Jerry.
Thank you, Sarah, and welcome everybody. I am pleased to introduce to you Dr. Nid Afdhal, a renowned expert in the field of liver disease. Many of you have probably heard him speak multiple times. Dr. Afdhal is a senior physician at the Liver Center at Beth Israel Deaconess in Boston. He's also a professor of medicine at Harvard Medical School. Dr. Afdhal's clinical expertise focuses on the management of the complications of liver disease to include cirrhosis and portal hypertension. His research is focused at all levels and all groups of liver disease. He has spoken nationally and internationally many times over the years and received many awards, to include the American Liver Foundation Award for Excellence, Fulbright Scholarship, and an honorary degree from the Royal College of Surgeons in Ireland. Today's webinar is funded by EchoSyn's North America, the inventors and manufacturers of the FibroScan technology. This presentation includes information on the uses of the FibroScan device from published literature. EchoSyn does not intend to make any specific claims based on what is presented in today's webinar. The FibroScan is FDA cleared as a tool for the aid in the management of liver disease and is not intended for the treatment of any specific liver disease. And now I would like to turn it over to Dr. Afdhal. Nid.
Good afternoon, everybody, and thanks for joining this webinar. We're going to discuss today how to use liver stiffness cutoffs for clinical care in the management of our patients with chronic liver disease. We had, in the past, used liver biopsy as the major staging modality for determining the degree of fibrosis in liver disease, and this has really been replaced by non-invasive tests, both serological and radiological, including vibration-controlled elastography by FibroScan. One of the original sins, as we call it, of liver biopsy was that liver biopsy was a qualitative rather than quantitative assessment of the degree of fibrosis. And in fact, there's a big difference when one looks at staging according to scoring systems such as Ishak or Medivir and compares them to the actual degree of fibrosis present by doing image analysis on stained slides. And what you can see is that as the spectrum of liver disease goes up and as there is more quantitative fibrosis going from Ishak 0 to Ishak 6, there is not a linear increase in the actual amount of fibrosis, but rather when one gets to the higher levels of Ishak staging, one sees significant increases in the amount of fibrosis that's present using image analysis for quantitative collagen measurement, such that in patients with cirrhosis, almost 30% of the liver can be involved with actual scar and fibrosis. And this is contrasted to, for example, a stage 2, where it's only 3 to 5% of the liver that is actually associated with scar. So really, we never staged our technologies against the best measurement of scarring, which is the quantitative image analysis. This has resulted in actually a lot of discordance between pathologists. This is a study that we did many years ago involving 3 expert liver pathologists at the Beth Israel, at Duke, and at the University of Florida. And what it showed is that when one looks at the extremes of disease staging, F0 and F4, so no fibrosis or cirrhosis, the concordance is very good between pathologists. But in between, there's a fairly significant degree of discordance. And this is because, again, this is not a quantitative staging system, but qualitative. Transient elastography using the FibroScan technology measures the shear wave velocity of an impulse put through the liver and extending between 4.5 and 6.5 centimeters into the liver. The speed at which the shear wave passes through the liver correlates very well with the degree of liver fibrosis, as is demonstrated here. And what you can see is that as the liver becomes stiffer with more fibrosis in the F4 patients, one can see that the speed of the shear wave increases and that this is associated with a calculated liver stiffness that increases quite dramatically. Liver stiffness is a dynamic measurement. It's not just related to fibrosis, and this is one of the key points that we need to take from today, in that many different things can affect the stiffness of the liver and therefore also affect the elastography of the liver. And essentially, we can have depositions in the liver, such as fibrosis, which is a major determinant of the stiffness of the liver, but also tumors, infiltration with inflammatory cells, swelling of hepatocytes, increased ductular pressure from cholestasis and obstruction, increased venous pressure from liver congestion from right heart failure, and other unusual deposits such as amyloid or perhaps even iron can all affect the liver stiffness. And thus, when one evaluates liver stiffness clinically, one has to be aware of the patient and the patient characteristics that one is looking at. And this is important in the interpretation of liver stiffness. I'm going to run through some of the data that looks at how liver stiffness correlates with the degree of fibrosis, and I'm also going to then focus on what cutoffs we use in clinical practice. These cutoffs are not written in stone, but they are the best cutoffs that we have available today. The first study I'm going to go through is the large U.S. multi-center registration study for vibration-controlled elastography, which was published in 2015. This study was performed in a prospective fashion with associated liver biopsies in a phase 1, which was to identify optimal cutoffs in a population of patients with hepatitis B and C, and then phase 2, which was a large validation cohort. These are typical HCV and HBV patients, 18 years or older. All of them had liver biopsy within 6 months for phase 1 and liver biopsy within 6 weeks for phase 2. None of the patients were on antiviral therapy. And patients who had uninterpretable biopsies or who had FibroScan failure were excluded, as were patients who had ascites, decompensation, pregnancy, or a BMI greater than 40. We used the Medivir scoring system. This is the most traditionally used scoring system in the U.S. to stage the pathology. As you all know, this is just based on the degree of fibrosis. Initially, F1 is just mild portal tract fibrosis. F2 will have a few septa, F3 numerous septa, and F4 is the presence of cirrhosis with focal nodules. And here, this system is the most reproducible pathological scoring system, and hence the most widely used in the U.S. We looked at 237 subjects in phase 1, of whom 188 were evaluable with both adequate biopsy and FibroScan, and 670 patients in phase 2, where 560 evaluable with adequate biopsy and FibroScan. It's interesting, both the FibroScan failure rate and the biopsy failure rate were actually very similar. For FibroScan, 10% of FibroScans failed to meet the predefined criteria for adequacy, and in biopsies, 8% of biopsies failed to be adequate to stage liver disease according to the expert pathologists. These are typical HCV patients. They were predominantly male, predominantly Caucasian, with about 15% African American. U.S. patients, so the mean weight is high at 82 kilograms, BMI 27, and the majority of patients had hepatitis C. When we look at the staging of disease, what's very good about this is that this is almost a real-life cohort in that there is the full spectrum of prevalence of disease. This is not a highly selected liver population that is seen in a tertiary referral center. And what I mean by that is that about 50% are stage 0 and 1 in the phase 1, a little bit less, 32% in the phase 2, and then another big percentage is stage 2. So you're getting the whole spectrum, and only about 35% of patients have advanced fibrosis stages 3 and 4. And about 20% of patients had significant steatosis, between 5 and 30%. These are the box plots of the liver stiffness, showing the increase in liver stiffness as the METAVIR fibrosis stage goes up, showing that in phase 1, which is MP1P, and phase 2, which is MP2P, there is a increase in stiffness that is clearly significant as one gets to F3 and F4 fibrosis. However, you will notice that there is a significant amount of overlap. We measure diagnostic accuracy by looking at the area under the receiver operating curve, or the AUROC as we call it, and this is the AUROC for the phase 1 study. Here, a cutoff of 8.4 kilopascals gave an AUROC of about 0.88 with very good sensitivity, 81%, and very good specificity, 79%, giving a very highly accurate assessment of patients with fibrosis F equal to or greater than 2. Here it is for F equal to and greater than 3. The cutoff is at 9.6 kilopascals. And what one sees here again is area under the curve for sensitivity and specificity, again above 80% with an AUC of 0.921. And finally, for cirrhosis, we get the best measurement where a cutoff of 12.8 kilopascals gives us an area under the curve of 0.91 with 84% sensitivity and 86% specificity. The importance of showing this data in depth is not that this is the only data, but this is U.S. data, and therefore important for us to understand since it is in our patients and represents the largest United States study performed with serial evaluation of both FibroScan and of liver biopsy. When we apply these predefined thresholds to the validation cohort in phase 2, we see that it is, again, very similar. However, as with the majority of validation cohorts, there is a slight decline in the sensitivity and specificity that we see in the phase 2 study, and this is because you now take all patients that are being evaluated, irrespective of the quality of the liver biopsies, and include those patients. And so the phase 2 represents what's really much more a clinical practice-like paradigm. And here again, you see fairly good specificities and sensitivities, but not quite as good for F greater than 2 as it is for F greater than 3, F greater than 4, where the cutoffs in phase 2 really are equivalent to the cutoffs in phase 1. It's important to understand how is the reproducibility of liver stiffness measurements using vibration-controlled elastography. This is important to us because this is one of the ways in which we can feel comfortable that we're looking at something that we can reproduce and that we're comfortable with discussing with our patients. And here you see the intra-class correlation coefficient between 2 exams done at a time period of at least a week apart. And you can see that the intra-class correlation is very high between exam 1 and exam 2 at about 0.94, and the confidence intervals are excellent, showing that there is great reproducibility over short periods of time. These tests are done in the fasting state with at least a 3-hour fast, which is recommended for vibration-controlled elastography. Here is the operator-dependent differences. Again, these are patients where an experienced operator performed the test, and then a second experienced operator came in and performed the test again with about 15 to 20 minutes between the 2 tests. And again, you see intra-class correlation coefficient of about 0.98 and very good confidence limits, showing that experienced operators should be able to reproduce the results when done by 2, again, experienced operators. So the study in this U.S. patient population really showed that liver stiffness had a high accuracy for staging F greater than 2 liver fibrosis, and even more so for staging F3 and F4 fibrosis. The ROC was good at 0.91, especially for the exclusion of cirrhosis, with good intra-observer correlation. And a high BMI was shown to affect the cutoffs for vibration-controlled elastography. And again, the importance of this is that the new FibroScan device recommends the use of XL probe, and this should be used in patients with high BMI. At the time this study was done, the XL probe was not actually available. How do we compare across cutoffs for other studies done elsewhere in the world? And of course, elastography was used a lot in Europe before it came to the United States. These are some of the early studies of the early introduction of elastography. And you can see that the cutoffs for F greater than 2 and the areas under the curve are relatively similar to that we see in the U.S. study. I'm happy to say that the AUCs are actually even better in the U.S. study than reported for these studies from Europe. And for the majority of them, especially for the diagnosis of cirrhosis, you see area under the curves between 0.9 and as high as 0.97 for significant numbers of patients. Now, one of the key factors is how does this reproduce when one comes to clinical practice? This is not a research-based study, but this is a retrospective look back in the Beth Israel Deaconess Medical Center cohort of patients who had elastography performed. And what this is doing is taking all patients who came in with multiple different etiologies, including HCV, HBV, NASH, biliary diseases, etc. And it's using the cutoff as defined from the large U.S. cohort of 12.5 kilopascals and looking at the positive and negative predictive value for cirrhosis in this population. And again, what you see here is very good sensitivity and specificity, an ROC of about 0.94 with good positive and negative predictive values. And this shows the translatability of the clinical research studies into practice studies that we use in patients that are just coming into our clinical practice at BIDMC using the cirrhosis cutoff of 12.5 kilopascals. Now, patients are interested in their degree of liver stiffness and the amount of damage they have, but they're also interested in what is the predictability of liver stiffness in terms of its ability to predict outcomes over time. And we now have collected data both from Europe and the US on the utilization of non-invasive tests such as elastography for predicting long-term outcomes in patients. This is a study from France where they looked at varying degrees of liver stiffness and its ability to predict 5-year mortality and need for liver transplantation in patients with chronic hepatitis C. What you see here is that if you have a liver stiffness of less than 9.5 kilopascals over 5 years, there's very little progression of liver disease to hard clinical endpoints. But as the liver stiffness increases, you begin to see significantly more morbidity, mortality, and need for liver transplantation, such that as the liver stiffness goes from 9.5 to 30 to 40 to 50, you see significant numbers of patients, almost up to 80% of patients above 50 kilopascals, having significant mortality and or the need for liver transplantation. We did a very similar study that we published at the BI where we followed 667 patients for 3 years with a variety of different liver diseases, hepatitis C, NASH, and hepatitis B. Mean age was 51, predominantly males, and 24% of the cohort had established cirrhosis. They were followed for 3 years, and the clinical event rate over 3 years was 8% of patients. This is all clinical events, including development of liver failure with ascites, encephalopathy, or variceal bleeding, development of hepatocellular carcinoma, death, or need for transplantation. When we looked at this, the liver stiffness was compared to the liver biopsy, and liver biopsy was just a good predictor of clinical outcome as liver stiffness. And a liver stiffness of greater than 12.5 kilopascals, our cutoff for cirrhosis, had a hazard ratio of 18.99 compared to those with less than 10.5 kilopascal for risk of a clinical event. To put this into perspective, you have almost a 20-fold increased risk of a liver outcome if you have our cutoff of cirrhosis on your initial index elastography. Again, across all patient types, including not just hepatitis C. And then finally, just as equally as important, a liver stiffness of less than 10.5 kilopascals had a 99.2% negative predictive value for a clinical event in 3 years. And we're hoping to present our 5-year data in the near future to see how this translates into 5-year outcomes. Why is this important? Again, a cutoff of 12.5 kilopascals is something that one can use to discuss with patients their risk of liver-related outcomes. And the alternative, a low, less than 10.5 kilopascal liver stiffness, is somewhat reassuring of at least short-term reduced risk of clinical events occurring in that patient. In real life, when we look at our patients, we have a lot of questions that we ask. This is a very complicated looking slide, but it's very simple really. And what it does is it takes the various confounding variables and it puts them into what one needs to know as the clinician when one wants to evaluate FibroScan. So for example, for inflammation, what do we use for our inflammation marker? We simply use the ALT. Papers have been published showing that an ALT of greater than 100 is associated with an increase in liver stiffness. We must be aware of this because this can actually give an increase of as much as 2 kilopascals, which can change the staging of a patient's disease and therefore result in overstaging the degree of liver disease and should be discussed with the patients. The non-fasting state is very important. If a patient has eaten recently, again, one can increase the liver stiffness by 10 to 15%. And this is due to an increase in portal blood flow. Portal blood flow increases the liver stiffness by increasing the vascularity of the liver. And so we recommend patients fast. Initially, we said 6 hours. This has now been reduced to a 3-hour fast is totally adequate. Cholestasis can affect this. So the ALT FOS is our marker for cholestasis, and one needs to know that. Obesity, clearly the device now is improved in that it will tell you when to use the XL probe, and the XL probe should be used whenever it's indicated, and perhaps even in patients with BMI of greater than 30. We like to know the alcohol status because alcohol can cause acute inflammation that can increase the liver stiffness. And then probably the one where we fall down the most is not realizing that in a lot of our elderly patients there is a degree of right heart failure and hepatic congestion which can significantly increase this. We teach our techs to always ask about heart failure, but also to look at the patient when they're lying down and see if there's a visible JVP, since this can immediately give one a clue that there might be the presence of hepatic congestion. And finally, inexperience. Again, all of our operators here at the BI are supervised for their first 50 examinations until they become very comfortable with the device and its measurement, and then they're able to proceed independently. This is from one of the papers that we published on how to use this in clinical practice, and is looking at it a little bit differently, and it's really looking at it according to different liver diseases. And the reason that this is interesting is that different liver diseases have different cutoffs. Here we see the different diseases: Hep C, B, NAFLD, alcohol, biliary disease, and then the diagnosis of portal hypertension. And the various cutoffs that we suggest are shown here. So for hepatitis C is the most easy and the most straightforward. 7.3 to 7.5 kilopascals suggests significant fibrosis. Greater than 12.5 suggests cirrhosis. For hepatitis B, the cutoff is lower for cirrhosis, and it's between it's around 11.5. I'm going to give you definitive cutoffs at the end. NAFLD, again, cutoffs are lower once again in terms of potential for the presence of cirrhosis. And when we come to discussing CAP, we recommend that all patients have CAP scores performed who have any risk of NAFLD. For alcohol, the cutoffs are different according to whether you're drinking or not. If you're drinking, your liver is stiffer, and actually the cutoff for cirrhosis goes up quite dramatically in alcohol. If you're abstinent, the cutoff goes back to the same level of 12.5 kilopascals. Biliary disease, because of the effect of congestion on the liver, has a cutoff of 16.9 to suggest cirrhosis. And then there's a lot of data and evidence on portal hypertension where a cutoff of 20 kilopascals suggests what we call clinically significant portal hypertension, or an HVPG greater than 10. And it's certainly important to know that, because that should be a clue for performing endoscopy. In addition, the Portal Hypertension Club at the most recent Bovino conference suggested that a combination of FibroScan plus platelet count can be a very good test to determine which patients should have endoscopy for the presence of portal hypertension and clinically significant portal hypertension with large esophageal varices. How do we use it in practice? In essence, elastography is our EKG for a cardiologist. At the first clinical visit, every patient that we see, every new patient, has a transient elastography performed. This we use as the point of care test to determine the degree of liver damage in terms of liver fibrosis, and this enables us to triage the patient appropriately in terms of how we follow that patient. There's a lot of data that if you combine this with serological markers of fibrosis, you increase the accuracy overall. I'm not going to go into that today, and in many centers, serological markers are not performed. One could use the simple algorithms like the APRI score or the FibFor, which are based on clinical markers, but overall, the actual increase in accuracy that serological markers give to transient elastography is relatively small. This schematic looks at how you can combine the two. When they're concordant, you can go forward, and if there's cirrhosis, arrange appropriate evaluation with cancer and varices screening, no cirrhosis, disease-specific management. When they're discordant, what we usually do is wait a period of time, usually about 3 months, and repeat them. If they're still discordant, then that is the time that one considers liver biopsy. Since we established elastography as the main tool for staging liver disease, what impact has it had on liver biopsy in our center? It's had an amazing impact. We've gone from doing approximately 16 to 1,700 liver biopsies a year down to no more than 200 liver biopsies a year. So what's really happened is its utilization just for simple staging of liver disease has replaced liver biopsy almost completely. However, liver biopsy is still used for diagnostic purposes in unexplained liver diseases, and also for evaluation of specific issues such as post-transplant rejection, etc. Now, why is liver stiffness important pre-SVR in our HCV patients? It's really important because the liver stiffness has replaced most of the testing that we used to do by liver biopsy, as I said, and so treatment decisions are often based on F-score in many countries, including the U.S., where we still have, in many states, restrictions on access for HCV treatment for patients who score low on the FibroScan in the F0 to F1 range. And it is the commonest diagnostic tool that's being used and is accepted by most of the payers when one comes to HCV therapy. I'm not sure what you're doing, but certainly in our center, liver biopsy pre-treatment is extremely rare. And then risk stratification is based on the fibrosis stage. And by risk stratification, I mean making the diagnosis of cirrhosis pre-treatment is usually based on this, which leads to the need for monitoring, etc., post-treatment. These are the cutoffs that we use for staging for treatment here at the BI. You can see our cutoffs are fairly extensive in terms of where we have them. These are based on the US data and also based on our own clinical practice data for HCV. Now, I want to turn to what has recently come out just this month, which was the AGA Association Institute Technical Review on the role of elastography in chronic liver disease. This is a very, very extensive technical review of the literature, and it's not a practical document in that it doesn't tell you how to do it or how to use it or where to do it, but it is a review that looks at all of the aspects associated in the published literature with cutoffs. So it's actually quite interesting from the aspect of cutoffs. And this is their cutoff value reference. And again, for those of you who are using FibroScan and want to create your value cutoffs, this is the cutoffs that they have. They use the same cutoff as we do for cirrhosis and HCV, greater than or equal to 12.5 kilopascals. They give you a nice sensitivity and specificity, and they break the predictive value down into areas of low or high prevalence. And what is very, very noticeable about these is the very good negative predictive value. And it's very important to have a good negative predictive value. So you're essentially not going to call too many people cirrhotic. HBV, it's again the same as us. We had our cutoff at 11.5. They have dropped it down to 11. The HBV literature is not as good as the HCV literature. Sensitivities and specificities not quite as good. Neither is the positive or negative predictive value. Why the positive predictive value is not as good is because in HBV there are frequently patients with high ALT, and that high ALT can cause false positive increases in the diagnosis of cirrhosis. Alcoholic liver disease, again, this cutoff is for non-drinking alcoholics. And then finally, the cutoff for high-risk esophageal varices, they have 19.5. I suggested 20. So the AGA review cutoff value reference really is very similar to that we see. What you see missing here is the cutoff values for NASH. The reason for that is that the NASH literature is not as well controlled with biopsy-based literature and simply does not have enough for the AGA, did not feel comfortable on making cutoff value recommendations for NASH. Now this second point is something that I consider a little controversial. And this is the cutoff value reference for significant fibrosis for HCV, which is the only one they made a value for, at greater than 9.5. We would agree with this. Again, ours was 9.52 for F3 and above. But here, the AGA also suggested that post-SVR, a liver stiffness of less than 9.5 suggests patients can leave specialty care. And I'm not sure that there's enough data to actually support that statement, since one does not know what the long-term outcomes post-SVR are in terms of particularly risk for hepatocellular carcinoma. This data, which includes elastography data, is currently being generated in large clinical trials where we're following patients for up to 5 years post-SVR. These are patients with cirrhosis, with sequential FibroScans and other clinical evaluations, including MRI, to look at things like HCC risk. Why is liver stiffness important post-SVR? This is very key again, because liver stiffness post-SVR determines whom to discharge from follow-up care. And again, it represents the key to risk stratification for continuous monitoring for HCC post-SVR. This is data from a meta-analysis that's going to be published soon that shows that there is a significant decline in liver stiffness over time post-SVR. And that decline continues. This is in all patients, not just in cirrhotics. And this shows the degree of decline that takes place in DAA failure patients. Almost 4.5 kilopascal decline in liver stiffness. The decline is bigger in cirrhotic patients, but the percentage decline is the same in cirrhotics versus non-cirrhotics. Again, what is important here is, what does it mean if a patient has a liver stiffness of 14.5 pre-treatment and now has a liver stiffness of 8.5 post-treatment? Does that mean that the patient didn't have cirrhosis and that we can discharge him from our care as per AGA guidelines, or do we continue to need to follow him? Some people have tried to look at this, and this is a very interesting study done in Child's Class A and B patients who did not have liver cancer, who were treated with DAAs plus or minus ribavirin. These patients were followed, And you can see that there is still, in the first year of follow-up, 3.2% or 9 of these patients who develop liver cancer. And one of the key things about who was most likely to develop liver cancer was those who had high liver stiffness at the time of treatment and also post-treatment. What we're suggesting for patients now is that we reset the clock post-SVR and that we follow them post-SVR to determine when they can be discharged from the clinic. This is what I do. Again, this is based on a personal experience on what I do. But this is looking at what I call the post-SVR liver stiffness. And it's broken down into looking at those at baseline and then looking at those post-SVR. So we have people with less than 9 kilopascals at baseline, 9 to 12.5 kilopascals at baseline, and greater than 12.5 kilopascals at baseline. Our SVR rate at the BI is about 96%. And what we do is at the SVR12 visit, we repeat the FibroScan. If you started off less than 9 and you're less than 7 at the SVR12 visit, we discharge you. We're very comfortable with that. You're below the threshold for significant fibrosis, which is 9.5, and you have a post-SVR FibroScan, which we consider to be at the stage 0 to 1 level, and we discharge you. If you score between 9 and 12.5 kilopascals, so essentially at the baseline, you're somebody that might have F3 and F4, we repeat the FibroScan at SVR12 and again at SVR48. And if you're less than 7 kilopascals at both time points, we discharge you. And then finally, those who have a baseline at 12.5 kilopascals, we follow them with an annual FibroScan. And now, even if their post-SVR is below the AGA cutoff of 9.5. Why do we do this? Because until we have clinical outcomes data, we do not feel that it is yet proven that these patients can be discharged from monitoring for the risk of HCC. In the last few minutes, I'm going to turn to CAP. CAP, as you know, is an ability to use the controlled attenuation parameter to determine the presence of steatosis in the liver. It is computed from the ultrasound signals and guided by the actual stiffness measurement. If the liver stiffness measurement is accurate, then you will get a CAP score. The CAP score is shown there on the screenshot of the FibroScan device, showing a person who has a low liver stiffness of 4.8 kilopascals and a low CAP score of 174. The issue is how to interpret the CAP results, and this is a dynamic process that is currently ongoing. What does it tell us? It determines the presence of fatty liver, yes or no. It is excellent at that. It evaluates the presence of significant or massive steatosis. That's a yes, no. And it can be used to evaluate the course of steatosis over time. And there have been studies that have looked at CAP score, CAP interpretation according to the presence of steatosis on liver biopsy. And essentially, a CAP score of greater than 300 dBMs per minute is associated with a fatty liver confirmed. And we call that a high level of fat. Less than above 215, but less than 300 is mild to moderate steatosis. This has been validated in several clinical trials that have looked at the CAP performance versus liver biopsy and looked at the AUROCs under these things. These are multiple studies, relatively small numbers of patients, and not just in NASH, but in other diseases that have correlated the CAP performance versus the liver biopsy. And you can see that for most of these, they have a very good correlation. And the correlation is good across all degrees of steatosis. The low-level steatosis, greater than 10%, best at greater than 33%, and also pretty good at the high level of steatosis, greater than 66%. Now, when I said this is an ongoing data set for CAP, here's a very interesting study that was presented at EASL by one of these groups that was really looking at seeing how we can combine the combination of liver stiffness plus CAP to try to see if you can actually use NASH, diagnose NASH. And in this study, NASH was diagnosed using the standard FLIP algorithm. There was a cohort that was used for training and then a validation set. This was done in French, British, and American cohorts, and it's biopsy controlled, which is very interesting. You can see the clinical characteristics here. I won't go through them in detail, but these are high BMI patients, lots of diabetes, clinical features of NASH, and liver biopsies that show varying degrees of steatosis and NASH scores that are consistent with both fatty liver with NASH scores of less than 4, and 26% have a NASH score greater than 5 consistent with NASH. Using the FLIP definition, 58% of patients had NASH. And this cohort looked at the French, which was the validation cohort, the American validation cohort, and looked at it to validate it in these patients. Again, these are the clinical characteristics of the two cohorts. What's very interesting is that the French cohort is very biased because there's a lot of NASH patients in it. The American cohort is actually a much better cohort because it's much more representative of the percentage of NASH patients you see in the NAFL cohort. So of 154 patients, about 24 or 16% of the patients actually had true NASH. And what you see here is the area under the curves using this proprietary algorithm to diagnose the presence of NASH. In the American cohort, which I would focus on where the NASH prevalence is 16%, you see an hour that's very good at 0.85, not just to say somebody has fatty liver, but to say there's a high likelihood of NASH being present in that patient. This requires further study and validation, but it shows you our thinking as we're moving forward on how to use vibration-controlled elastography to try to even further enhance how we evaluate patients with NAFLD, to try to use that combination of stiffness and CAP to categorize patients into whether they're likely or less likely to have NASH. And again, as this is a point-of-care test, it's a little bit easier to do than the other excellent test in this space, which is MR-based elastography. So I'm going to stop here so that we can have some time for questions. I hope that what I've shown you is that FibroScan is now a major player in clinical practice, that it does require experience and it does require understanding the patient's clinical characteristics to get a proper FibroScan test that you can interpret and use appropriately in clinical management. For those of you that use biomarkers, they are complementary, and they are complementary to biopsy. Liver biopsy is always going to be there, and it's always your backup if you're unclear or uncertain, or there's discordance, or you don't believe your results. And one should never be worried about liver biopsy. We've been doing it for over 50 years. Cutoffs for staging are pretty accurate and adequate, certainly for HCV therapy and insurance approval. HBV, the cutoffs are pretty good, taking into account the fact that the ALT elevation can be a major player in HBV in terms of making sure that you correlate it and account for the ALT elevation. And that really the key thing is that in the long-term follow-up, we need to keep correlating the FibroScan findings with clinical outcomes to determine when we can use FibroScan to discharge patients from HCV care, and when we can say to patients their risk of hepatocellular carcinoma is being reduced post-successful SVR for hepatitis C. Thank you very much for your attention, and I will hand it back to the organizers for the Q&A session.
Thank you, Dr. Afdhal, for that very informative presentation based on many years of FibroScan clinical usage. We now want to open the webinar for a question and answer period. My colleague, Dr. Sunil Hasmain, is going to help us with the questions. A reminder to all of the participants, you have a question field on your screen. Please type any questions that you have into that field, and Sunil is monitoring those fields, and he'll be reading the questions to Dr. Afdhal. Sunil, could you please go ahead and pose the first question?
All right, thank you to the speaker for a wonderful talk, and I just wanted to preface by saying that we will try our very best to get through all these questions, but inevitably we will not be able to do all of them, so sorry in advance for that. The very first question goes back to kind of the beginning of the talk, talking about factors that influence the FibroScan measurement. The question came in, does portal vein thrombosis impact liver stiffness?
That's a very good question. You know, we don't have a lot of data on that. One assumes that portal vein thrombosis might reduce the liver stiffness since you don't have as much portal blood flow. However, I would think that that would be minimal because in the fasting state, the portal blood flow is relatively low. And obviously, it depends on the etiology of portal vein thrombosis. If it's a thrombosis secondary to somebody with cirrhosis and low stagnant flow, you'll have a high FibroScan. If it's a young person who has a post-traumatic or a post-infectious portal vein thrombosis, you might find a very normal FibroScan because they have very little liver fibrosis. The one disease where we know there's an association is here you frequently have portal vein thrombosis, and these patients have a lot of peri-portal vein fibrosis. They have that typical what we call pipe stem fibrosis, and they have high elastography scores. And
adjacent to that question is another one that's somewhat related. Seemingly the populations in these studies are predominantly male. Is there any significance of sex in the measurement testing?
You know, to date, there hasn't been a lot of gender differences that I'm aware of in terms of elastography. Certainly the HCV populations are about 70% male. We're seeing in the NASH data actually very high female prevalence. So we're getting more data on that. You know, I am not certain if in the so-called normal patient population, whatever a normal person is, whether there's been described any significant gender differences between male and female.
Thank you. Next question is certainly a very important one in the field and is evolving. So the question was posed, NASH as it's defined today is done primarily through pathology and hence the biopsy. Can you use VCTE or maybe VCTE in combination with CAP in place of the biopsy to diagnose NASH, or do you do the biopsy first and subsequently follow with a combination of VCTE and CAP to say monitor annually or some cadence?
You know, I think the problem that we face as clinicians is that we're beginning to see more and more people who have risk factors for NASH. Those are people with obesity, diabetes, and even some people with lean NASH and abnormal ALTs. What we can't do is we can't biopsy all of them. So what is the role of VCTE plus CAP? And I think that role is twofold. The first role is that if you have an increased liver stiffness score above 7.5, which is consistent with F2, that person by definition has significant liver disease and NASH and needs to be considered as somebody because he has fibrosis, and fibrosis is bad. Fibrosis is the predictor in NASH of clinical outcomes. So if you have a high FibroScan score, then you already know you have significant NASH or significant fibrosis. And whether they've got apoptosis or steatosis is irrelevant. They have liver disease. So that's the first way I use the FibroScan. The second way is to see that in those who are scoring in the lower score or a little less, what we call little indeterminate, you know, you could potentially use that data that I showed you on combination of liver stiffness plus CAP score to enrich for the presence of NASH. And maybe those patients are the ones that we should be biopsying, where you have both a borderline level of liver stiffness, so instead of being above 7.5, maybe it's just 7, but you have a high level of steatosis. And then you biopsy those patients because you may find NASH in those patients. The other way that it's used, and again, data is determined, is to look at change over time. One of the great things about this compared to liver biopsy is its ability to follow a patient sequentially. Whether that patient have HBV and you're trying to determine whether you need to treat him, he's got a normal ALT but a positive viral load, you follow it over time. Whether you have somebody who has potentially got NASH and you can follow them on an annual basis and determine when and if you need to intervene. So I think that all plays into it. Again, we don't have rigid guidelines for this because we just don't have enough data. I can't tell you if my patient whose FibroScan score for NASH was 5.8 2 years ago, then 6.1, and now 6.8. I can't tell you whether that means he's progressing, but I can tell you that it increases my monitoring of him and my desire to do a liver biopsy if clinically indicated.
Oh, thank you for that. And that actually dovetails very well into questions around disease progression, regression. So it seems that not only is the, we'll call it baseline measurement, very valuable, but then subsequent changes. Do you use different testing cadences? For example, do you bring in a NASH patient versus a NASH with fibrosis patient versus a NASH with cirrhosis patient in for checkups at different times?
That's a great question.
Subsequent follow-up.
That's a great question. Right now, essentially what we're doing is we're doing baseline in everybody, as I said, at clinic visit number 1. And then most patients have an annual FibroScan. And we follow that FibroScan over time. And again, it has great value. There are certain diseases where we're not intervening, where the FibroScan gives us a tremendous confidence of not intervening. I mentioned one of those, which is HBV, with usually E-negative patients with indeterminate viral loads, so anywhere between 2,000 and 5,000, with a normal ALT who are young. We follow them every year, and if they don't change, we usually don't treat them. NASH is the same thing. NASH patients with a low FibroScan score, or NAFLD patients with a low FibroScan score, annual elastography to follow them and look for changes over time. And we're learning. So I've had this toy for almost 12 years, but we're still learning all the time how to do it.
Thank you very much. That was extremely helpful. We've been getting some questions, and so I'm going to essentially lump them together because they're effectively asking for similar things. Can you make a comment about the IQR median ratio and its impact to the accuracy of the test and how you may view it, interpret it, and when you're looking at a FibroScan examination?
So, we say a valid FibroScan is 10 valid measurements and an IQR of less than 30. We know that 8 valid measurements is just as good as 10. But we also know that the lower the IQR, the more comfortable you are in terms of the validity of the measurement. So if the IQR is very tight, less than 10%, I really like that measurement. I usually say that's a very high quality FibroScan. If the IQR is between 10 and 30%, it's still valid, but the degree of certainty is probably a little bit less. Not enough to change your cutoffs or change your practice, but that's how I visualize the IQR. So for example, if I have a young person that comes in and they have a FibroScan of 5 and the IQR is 8%, I'm like, you definitely don't have to worry, go away, come back in a year, we'll check it again. So I use it from that perspective, but we do use it for above 30, we do look at the validity of the scan, we look at the quality of it, and sometimes we will say, scan not valid, and we might repeat that 3 months later.
Thank you. Another question is potentially some cross-correlation. So can a high CAP score influence a high KPA score or influence the KPA score at all?
So this is a really good question, and the literature is quite variable on this. So you don't get the CAP score unless the stiffness score is valid. So the first step of the algorithm is to make sure that the actual FibroScan score is valid. There are 2 schools of thought on the degree of steatosis and its effect on liver stiffness. One school is that there's no definite effect of steatosis itself on liver stiffness, and there's been many studies that have suggested that. There are also a couple of studies that suggest that a significant degree of steatosis can cause a lower overall FibroScan score, so it can reduce the actual liver stiffness score. So, again, I would look at it in this way. I would look at the liver stiffness for its validity, and then I would look at the CAP. The CAP is really high, above 300, suggesting massive steatosis. and the stiffness is a little elevated, I would label that person as probably NASH, probably significant fibrosis, and consider, if necessary, doing a liver biopsy. I would only do the liver biopsy if I was going to put them in a clinical trial or I had a specific therapy in mind. I mean, there's not a lot of need to do liver biopsies in these patients unless you have a specific reason for doing it.
Going back to a topic that was mentioned briefly in the beginning, is there any data regarding FibroScan either replacing or showing strong correlation to portal pressure, so portal pressure gradient measurements? And a secondary question is validity in hemodialysis patients.
So the answer to the portal pressure is yes, there's excellent studies showing correlation. There are studies that show that the FibroScan correlates with HVPG, and there are studies that the FibroScan correlates with the presence of large esophageal varices. So that cutoff of 20 is associated with what we call clinically significant portal hypertension, which used to be above 12 millimeters of mercury, but is now being dropped down to 10 millimeters of mercury. So that's a strong correlation, and there's also a correlation of greater than 20 with the presence of esophageal varices. So there is this association of stiffness with varices and with clinically significant portal hypertension. The dialysis population, I haven't seen a lot of data on dialysis, but there should be no reason why FibroScan is not a useful test in dialysis patients with the same cutoffs, unless you have fluid overload. If you have fluid overload, you have the potential for right heart failure. If you have any degree of right heart failure, the liver stiffness goes up. I can't stress that enough. You don't have to be in gross right heart failure for the stiffness to go up. Even a little hepatic congestion raises the liver stiffness significantly. And when I say significantly, I mean significantly.
Thank you for that. Another question, which has been manifested a few different ways. I'm going to pull it together. Essentially, are there differences in cutoffs between these two probes that are often discussed, M probe, XL probe? And a question that has arisen is, should all patients just be scanned with the XL probe given the obesity epidemic?
So I think one of the most useful tools on the actual FibroScan device is its ability to tell you which probe to use. When it recommends that you use the XL probe, use the XL probe. It's not based on the obesity issue. It's based on the skin thickness that's there between the intercostal spaces, and the amount of subcutaneous fat is what determines the ability to get a good shear wave into the liver. So I always recommend using that. Are there differences in cutoffs? Not really. Not to a degree that would make a difference for the diagnostic levels that we use. So we do not correct cutoffs for probe. What it's telling you when it says use the XL probe is it's actually telling you that the XL probe will give you a more consistent, better validated read in that patient. And the cutoffs for that patient are the same.
In this presentation, we discussed, and for very good reason, cutoffs that correlate to different levels of disease severity. Flipping it around to the other side, which range would you consider to be these patients to be clinically fine or clinically healthy? Which cutoff below which?
Less than 5. Less than 5 is perfect. So if you see a patient who comes in and their FibroScan is less than 5, they don't have any significant liver disease. Less than 7.5, some HBV patients will be false positives. Some NASH patients will be false positives. So, one has to think in that 5 to 7.5 range, is there any disease? Safe in terms of clinical outcomes, certainly less than 9.5. We actually use 10.5 as our cutoff. I'm comfortable that they're unlikely to have a clinical event in the next 3 years. So we do absolutely use those low levels to reassure patients there's no significant disease. And I think that one should be very comfortable. And I am completely unaware of any data that a FibroScan less than 5 is associated with any significant disease. In fact, when we looked at the 800 patients in the U.S. study, less than 5 was always stage 0. There was nothing there. All right, so I'm very comfortable with that.
All right, thank you, Dr. Afdhal. Well, this concludes the question and answer portion and today's webinar. So on behalf of EchoSense, I'd like to thank Dr. Afdhal and for his talk today, and thank you, the listener, on this very important topic. This webinar has been recorded, and you will receive a follow-up email with a link to where you can download that recording from our video library. And you will also be met with a 5-question survey as we conclude this webinar. If you don't mind taking a minute to fill that out, it'll help EchoSense with their ongoing improvements. All right, thanks again.
All right.